I would like to welcome you to today's webinar, which is using patient data to understand where we begin. And this is the first in the series of Improving Ohio Health webinar series. Today's speaker will be Cathy Costello from the Ohio Health Information Partnership, also known as CliniSyncPLUS. She is the Director of CliniSyncPLUS Services. Now, before I turn it over to Cathy, just a few housekeeping items. All attendees are muted upon entry into the webinar. If you have a question at any time, go ahead and enter that into the questions feature of the GoToWebinar app. If you can't find that, enter it into the chat box and we'll see it there as well. Now, we're going to answer all the questions at the end of the webinar. Also, this webinar is being recorded and will be posted to the CliniSync YouTube page here over the next few days. There are a few handouts that were emailed to attendees prior to the start of the webinar today. But if you didn't receive them or you don't have them handy, if you can find the handouts feature in the GoToWebinar app, you'll be able to download the three documents there as well. So with that, I would like to turn it over to today's presenter, my good friend, Miss Cathy Costello.
Thanks so much, Scott. Appreciate Scott is the one who keeps me on the straight and narrow, technically speaking, on these webinars. So I appreciate him being here. And I have to say a big thank you to the Ohio Department of Health in their chronic disease program. They have been wonderful working with on this on these grants that have been designed to address chronic disease treatment and programs within the state of Ohio over the past year or two and going ahead for the next few years. So let's see where we are here. There we go. Okay, I think today what we're going to do is to frame for everyone what it is that Medicare Center for Medicare and Medicaid Services, so includes Medicaid also, is doing in the area of chronic care management. And then specifically we're going to look at what Ohio's doing and the programs that Ohio is working on, and then end up looking at the statistics that many of you have helped us to collect across the state. Today's webinar is involved with the inpatient data that was drawn on hypertension and diabetes, but we have a series of webinars, and we'll run through that at the end, in which one specifically will deal with the ambulatory setting too. So let's see what we have here. I think in order to understand why what we're all so concerned about now is such a problem, I think all you need to do is to look at the statistics, both nationally and in the state of Ohio. 86% of all U.S. healthcare dollars is related to chronic diseases. And to put that in terms of actual dollar signs, which are higher than most of us can even comprehend, but what you're looking at is $3 trillion. $3 trillion as of 2014 is spent every year in the United States on healthcare expenditures. So if you're saying 86% of that goes to managing people with chronic diseases, then what you're saying is well over $2 trillion it goes to trying to take care of people with chronic diseases. And so it becomes very clear that this is why this is such a huge priority for CMS in how to handle this. Then if you look at the flip side of that, and the reason we're talking specifically today about the inpatient costs is inpatient or hospital costs in this $3 trillion account for almost a full third of all the costs. So almost $1 trillion nationally in a year goes towards supporting hospital inpatient costs. So when you consider the two, the number of chronic conditions or people with chronic disease that are driving the healthcare costs, and then the percentage that is involved with hospital inpatient costs, you can see putting those two figures together, how important it is to kind of arrive at a new way of doing things in helping to manage and control these problems. In Ohio specifically, we account for almost 4% of those costs, and for diabetes alone, we have $9.3 billion, $9.3 billion of the U.S. Economic costs to treat diabetes were coming from the state of Ohio. And in 2013, we had almost 1 million people within the state have been diagnosed as diabetic. And this, unfortunately, for us, puts us in 7th place in the country with the number of diabetics that we are that are residents within the state. And I know we're a competitive state in a lot of ways, but this is one place we don't want to be competitive. So let's look specifically as to how Medicare is tracking this. As we said, the dollar figures are pretty staggering, but how is Medicare rolling this back to make this meaningful discussion in what we all want to know, and that is, how do things work in our communities? We can talk about trillions of dollars, and as I said, it's kind of a hard figure to wrap your head around, but honestly, when you take it down to the local level, it gives you a much better picture. So what Medicare has done, starting in 2014, they had a number of pilots before then, but it was generally available with 2014 data reported in 2015. CMS has begun this new method of tracking costs and then paying for the services they receive. And in the tracking cost side, what they've done is they have created these reports called Quality and Resource Use Reports, better known as QRUR. If you haven't seen them, they're pretty impressive. And what they have done is for every single hospital and physician tax ID in the country, they have created these reports that track cost and quality parameters and lets individuals and organizations know basically how they've done. In order to do that, what they've done is, some people say it's arbitrary, but it's the best way available right now, is they've attributed covered lives or Medicare patients to that tax ID based upon the primary care services that are given to that patient. If you are the physician or organization that provided at least 50% of the primary care services, then that patient is considered yours no matter where they received care across the continuum. So it might have been in your office, it might have been in the hospital, it might have been in a long-term care setting, might have been home health care, but it all gets bundled up and attributed under that tax ID for costs. If there is not a primary care provider who provided the bulk of the services, or an organization that provided the bulk of the services, then they do an attribution based upon looking at the specialty services and determining who provided the most care. But one of the keys in these QRUR reports, and you'll see it time and time again, and we'll look at that in just a minute, is Medicare did something that I really think was brilliant. It was very simple, but it's really brilliant because it's going to help you all determine how you can best serve your patient population. And what they did is, for every single Medicare beneficiary who has been attributed to your organization in that year, they have tracked 4 specific chronic conditions and said whether or not that patient has that condition. And the 4 conditions are diabetes, COPD, coronary artery disease, and heart failure. And as you'll see over the next few slides, these 4 conditions are literally mapped not just to the individual, but then fed back into the data for your organization overall to see how these particular conditions are affect your inpatient costs, your ambulatory costs, and other costs for that particular condition. So it's a really important metric, and what Scott and I do a lot of work out in the field in helping people to address issues about how to manage their patients. And I know this is one particular set of criteria that we found really extraordinarily useful because, and you all can do this yourselves without a problem, is to take this information out of the QR-UR report and map back those 4 conditions to see how many of your patients have no chronic conditions, how many of them have 1, 2, 3, or 4, and then develop your care management plan to address those areas that are most significant in your particular community and organization. So let's see how this is reflected in the reports. This first report, and these reports are generated for, as I said, for any organization or practice or provider that that produces or covers Medicare and that has a QR-UR report generated. So you can look through it. These reports are about 13 or 14 pages long, as summarized and with a lot of underlying reports that can track back to the individual patients. But the 14-page report is a great overview. And the first quality metric that we're showing being tracked for the inpatient side is for all the Medicare patients that your organization takes care of. They will track the hospitalization and readmission rates. And they track it, they make it into a quality indicator for the work that you do with those patients. So even though this information is based upon claims data, it is assigned certain quality criteria based upon how you compare with the benchmark for all organizations across the country. So this one, let's look at this here. Let me see if I have, yeah, okay. The 3 areas that are tracked, and as you can see, this is hospitalization rate per 1,000 beneficiaries is the metric here. So they track according to, break it down into categories. You have your acute conditions, your chronic conditions, and then all-cause readmissions. And the acute condition is just that. It includes everyone and excludes the chronic condition information is broken out separately. But in this hospital's case, or this organization's case, they had 1,388 patients within Medicare patients that they handled, and they had an excellent result here in the sense that in their acute patients, they had 6.5 hospitalization per 1,000 versus the national average of 7.5. And so because they were had a lower rate of hospitalization for their acute conditions, they were assigned a positive quality score. So this is good. Positive is good in quality and is bad in cost. But on the chronic side, and you'll see this, as I said, for every slide, what CMS has done is taken all the patients that were admitted to this hospital, or to this could be more than one hospital, but under this organization's control, they track diabetes, COPD, and heart failure. And this is where it gets a little bit trickier, because this organization's performance rate, so their rate of hospitalization was higher than the national average. So they had 58 hospitalizations per 1,000 versus a national average of 50. So they received for their chronic condition management a minus quality rating, minus 0.33. And they break it out by specific category. And what's so interesting about this, and this is why when we're working with people, we say, look at your figures, determine what your own resource capability is as far as setting up support programs, but also look to see which areas you're strong in and which areas you could use more help in the chronic condition area. Because in this case, in diabetes, this organization is doing fabulously. Their diabetics are only hospitalized 7 per 1,000 versus a national average of 18 per 1,000. So very, very good rate. But then you come down and look at their COPD and their heart failure rates. They're much higher than the national average, especially in the heart failure, where they're 144 versus a national average of 99. There are many reasons this can happen. Sometimes we see tax IDs where because of the workflow and where the patient or the physicians who handle the most chronically ill people are reported, that this may represent a much higher and sicker population. But it recognized that this is the way that CMS does analyze it. The all-cause hospital readmissions is an area that I think you're all familiar with. This started a few years ago, but every hospital is judged every single year, or is rated every single year against the national averages for patients that have been re-hospitalized within a 30-day period. And this is obviously an area you definitely want to be lower than the national average, because the hospitals no longer get paid for patients who get readmitted within 30 days. And so this hospital did very well. They have a positive rating because their averages are lower than the national average. Now let's see how CMS tracks that according to cost. They do the same type of analysis, but they attach actual cost figures. And so what you're seeing, I just want to explain here what you're seeing. The top line, per capita cost for all beneficiaries, is basically the cost for those who are hospitalized. And it includes the cost from 3 days before a hospitalization to 30 days afterwards. So no matter where the care is provided, whether it's inpatient or whether it's outpatient, long-term care, at home, whatever it is, all those costs get rolled into this figure here. The line below it, the Medicare spending per beneficiary, is the cost for all patients divided within the year's time. So it doesn't matter whether the patient was hospitalized or not. So you're going to have a lower cost here because this includes a lot of your patients who just receive care on the ambulatory side. But then as you move down, again, you track by specific chronic disease. So you have diabetes, COPD, coronary artery disease, and heart failure. And what CMS does is they figure out, again, they take the same patients and figure out how much money they spent for your organization to take care of those patients. And then right here they said for hospitalized patients, it costs them $43,000 with the benchmark being $10,000. So this was a significantly higher figure than what you would expect to see compared against the national average. And as I said, this can get a little tricky on the analysis because a lot depends on how many of these critically ill patients are handled within this tax ID. But as you can see, it's almost 4 times the rate of the national average. And so consequently, in this cost category, don't forget costs, you want to be on the negative side. You want to be lower than the national average. But here, this group is almost up at a 12, which is very, very high. So again, that's one thing that you want to look at here. But the interesting thing is their overall costs, so their ambulatory plus their hospitalization, is lower than the national average. And so they get bonus points for that. So as I said, it can really look kind of fluky if you don't understand what you're looking at. But as you go down the line, their treatment of their diabetics within the hospital was quite expensive, 4 times the national average. And their COPD, again, was quite high. In fact, in all these areas, they were higher than the national average. This is not the same group as the page before, but I'm just showing you how this gets tracked. And consequently, their figures were adversely impacted. But the nice thing, this last column over here tells you whether or not these figures get counted into your score. And the significance of that is it can affect your reimbursement. The reason these aren't counted, though, if you go back over here, this is a small organization. It's a very small organization, very few patients treated inpatient, and consequently, the impact of a few critically ill disproportionately impacts the cost of treating that person within the hospital setting. And so that's really what drives up the cost. So if there's very few patients, if there's less than 20 cases, it does not count toward your averages. The last thing that CMS does when they look at chronic care expenses is they split out all the costs, whether it's the ambulatory costs, the E&M costs for office visits, any procedures like surgical procedures that are done, minor procedures, hospital services, emergency room services, post-acute, which includes your long-term and post-acute care facilities, rehab, and hospice are the categories that they look at. And again, those get broken down many times over. But what I just want to draw your attention to here is that the hospital inpatient services that we'd looked at on the other pages then get split out again by chronic conditions. So this was your total cost column, the one on the left. This is the diabetes column is the next one, COPD, coronary artery disease, and heart failure. So in this hospital's case, they were slightly higher than the national average on their cost of inpatient hospitalization costs, $135 more than the average, more than the average by $500 for diabetes. But then you get over here and their COPD costs are quite good. They're almost $2,000 less than the national average for everyone they treat with COPD. So you have to look at this all, and you get kind of caught up in all the details. But if you do the 50,000 foot level and just look at it in relation to your chronic diseases, it can help you, as I said, structure a program that is responsive to the patients within your community. Okay, so let's look at what Ohio is doing, because I think Ohio is to get many kudos for what is being done. What we're doing here and what this webinar is related to is what the Center for Disease Control has put out, and as you know, that's the public arm of the United States for population and public health. And so they put out these grants to improve population health and to address chronic diseases. And Ohio was very fortunate to be the recipient of 2 of those major grants. The grants go to, actually all states received 1 of the grants, but then Ohio was one of 17 states that received an additional $17 million to address chronic diseases. And the grant is broader than just the question of what we're doing here, collecting data for the hospital side, for the ambulatory side, to see what the state is doing. The grants are very broad, and they really look to address population-wide approaches to obesity, diabetes, heart disease, and stroke, and to set up programs in priority populations to support those. And so this includes stuff like healthy eating within the schools, setting up, not education, but exercise programs for populations that need it, working in all kinds of ways to join the communities together so that everyone in the community involved in healthcare knows what the resources are locally and can help establish programs that will support those patient populations. And I think that's been one of the greatest things about this grant is to see all the work that's being done out in the field to support and push these programs. And the second grant, part of the second grant, goes specifically to supporting public health initiatives in 6 of the counties, Lorain, Athens, Montgomery, Richland, Summit, and Washington. And we're not going to spend a lot of time on those today because that's actually going to be part of another of the webinars in this series, because I think those counties are doing a really fabulous job of reaching out to their communities and working with them. And so we'll highlight a couple of those in our next program. What we're talking about here today specifically is part of the grant that goes to establishing the baseline for the state of Ohio and understanding where we are with diabetes and hypertension, which obviously would lead to stroke and many other chronic conditions if left untreated. And so our involvement has been to help the Ohio Department of Health draw data from all around the state. And we're literally talking about over 100 hospitals, thousands of individual providers, to try to get a feel for where Ohio is. As looking back on that first slide, we know that Ohio has a problem with chronic disease management. What we don't know is specifically what the footprint is around the state. And so beginning down here where we're collecting reports on clinical quality measures for inpatient and on the ambulatory side, collecting demographics to understand the patient population that is being affected by these grants as they get put out into the community, to provide education about chronic care management and, as I said, programs supporting the individual patients, and then work in conjunction with other quality initiatives so everyone doesn't feel so overwhelmed with having so many things asked of them to do in quality initiatives, and then do a yearly update. So these grants run for the next several years, and this is only the first in a series of reports that we'll have for you about how the state's doing. And hopefully when the grants close out in 2018 and 2019, you'll be able to see improvement in your community and in your organization. So the baseline that's being established here, as I said, we're talking specifically today about the inpatient figures, but we also we'll have a whole set of ambulatory figures for you. So what is being done with the hospitals was we were able to work with the hospitals and with the Ohio Hospital Association to get information on inpatient discharges for patients who were identified as either diabetic or hypertensive or both for every county in the state. And then couple that with demographic data so we have some idea of the number of patients that are being covered or in this baseline. So we have some idea of what the population figures look like. And then on the ambulatory side, there's 2 figures that are being tracked. And these are ones that are very, very common. Any of you who practice in the outpatient ambulatory area are well aware of how many times you get asked about these. One is NQF 0018, which is the person's blood pressure less than 140/90? And NQF 0059 is A1C for diabetics in poor control, so it's greater than 9%. So those are the metrics that are being tracked. They're actually fairly simple, looking for the number of diabetics and hypertensives who are discharged from the hospital, and then in the outpatient setting, ambulatory setting, how many of those hypertensives are in control and how many of the diabetics are out of control. So the way this information is being used is strictly at the aggregated level. Individual organizations and providers are not identified. They are identified only by county. The county information gets pulled together through our organization, and we then report it to the state, who again reports it to CDC to compile as part of the national figures. And the goal, as I mentioned, is after these grants run, the hope is that by identifying what the need was and putting the resources into the correct areas and doing the education and providing a link with the patients, that we can improve that healthcare outcome. The information that we're sharing with you today is 2014 data, but we will have the 2015 data within the next couple of months for point of comparison. The data, as I mentioned, is totally de-identified and will be updated every year. Let's see where we are. Okay, this is the actual data as it was reported. In Ohio, and this is all hospital-based data, in Ohio, for those patients who were inpatient, we had 1.1 million discharges, and of those, 43%, so almost 500,000 of them were diabetic, and 56%, or almost 6 in 10, were hypertensive. So it is clear from the data that was collected that the American Diabetes Association was right on point in those figures that we looked at in the first slide about the fact that Ohio is 7th highest in the state, in the country, on the rate of diabetes. And I think that's reflected with even higher figures too on hypertension. And so it's, I don't think there was a mistake made there at all from the data that we saw. The lowest or the best rating is the central region, which is this territory around Franklin County. But when I say the best, that's all relatively speaking, because even in the central region, 4 out of 10 people discharged from the hospital had diabetes, and 53% had hypertension. And then that rises, the highest level is the southeast region, which it moves up and has almost 47%, it has over 47% were diabetic, and literally 6 in 10 had hypertension. So as we look at that, here's a visual of what we were seeing with the statistics. And the interesting thing here, and we didn't think to do it before, but I think maybe we will with the next one, and we can go back and look at this, is maybe to look at population age in each one of those regions to see if that's a determining factor. But there's definitely good programs in many of these regions that support the work with the diabetic and hypertensive patients, and those are the ones that we hope to share within the next few months with you, so you can understand what is occurring that may be affecting these rates. The good thing that I'd say about these figures is the Northeast region has the highest number of discharges, over 400,000 discharges, and yet their rates still not significantly more than the state average. The region that has the highest rate of diabetics and hypertensives is the Southeast region, But again, the good news is that it's a lower number of discharges. It's less than 100,000 discharges. So I think the establishment of programs in these areas to treat chronic conditions will actually be able to move the needle faster because there's fewer patients involved. So it's just one of those areas that you have to look at carefully, because there's a lot of good information there that can affect what you all are doing as both a region and as a community. Now, by specific counties, that's something that I think all of you are going to want to look at in relation to your own counties. And you almost have to look at the larger counties separately. For example, Cuyahoga, where Cleveland is I don't think doing too badly. They're actually a little less than the state average in diabetes. They have less than 43%, and are a little bit less on the number of hypertensives that are discharged, and that's less than 56%. So there are things that you want to look at specifically. I do think it's kind of interesting, though, that the absolute lowest figures are in Delaware County, where you've only 34%, so basically 1 in 3 is diabetic, and just over half the population that is released from the hospital has hypertension. But generally, and I don't want to make overall general statements that have a lot of, qualifications to it, but generally some of your, it's not so much rural, but I'd say some of your farm community areas on the western side of the state have very low figures. We've got, for example, Wyandotte has very good figures. Warren has very good figures. Williams County has very good figures. And I can't honestly say what that accounts for. Maybe it's just that there's a fewer number of people who are hospitalized, but that's just one thing that struck me as we're looking at the figures, that there are differences that I think pertain back to the region where the information is coming from. So I would encourage you to look at that with an eye to what you're doing in your own area. Now, the one thing that I'd say is, as we mentioned, we are a top 10, and this is one of those times you do not want to be a top 10. We will let Michigan take the honors for top 10 rather than Ohio. Michigan also got one of these grants, so it's going to be interesting to see as a region how we all do, because honestly, I think that's something that is usually commented on at the national level, is that the Midwest has higher chronic problems, but hopefully we can prove them wrong over the next few years. So one way to handle this, and we're going to look at this in a great deal more depth over the next couple of months, but CMS has set up, because they have such a stake in how chronic care is managed in this country, they've set up 2 new coding billing codes over the past 2 years to handle hopefully these patients that need additional care. And one's called transitional care management, and I'm sure that many of you have already set up programs around this, but if you haven't, please look at this. And the coding in this area, there's actually 2 codes, but they're based upon the severity of the illness, and but they're both the same identical program. And that is basically to provide care for patients who transition out of, usually you're talking about a hospital inpatient setting, but there's other settings too that could be included. But basically you're trying to catch the patient as they're being discharged and bring them back into an ambulatory setting to see a provider, to have that provider see them within a week to 2 weeks of the time of discharge, to see what additional care they might need, or to see how they're doing. Are they taking their medications? Are they recovering from surgery? Are they recovering from pneumonia? Is there anything else that they need done? So it is CMS's recognition that if you can take care of that patient as they come out of the setting, you're less likely to see them back in the setting within 30 days. And so this is a key thing. And honestly, I think Scott and I have seen probably this one implemented more frequently than the second one, the chronic care management. And I think that's because both hospitals and the ambulatory physicians and other providers recognize this as such a key. You know, the hospitals got onto this coding within the past few years when they started getting losing payment over patients that were being readmitted, because no matter whose fault it was, it's the hospital that is basically taking the hit financially for patients who come back in. And so the hospitals were the ones that were like, hey, maybe we need to set up a way to monitor these patients when they leave. So whether the hospital sends them to their own provider, sets up a special group that handles these patients as they come out, or whether they allow them to flow back to their own primary care practitioner and they just let the primary care practitioner know that that patient's been released, no matter how it's being set up, this is becoming a more important and more common coding. The second code, the chronic care management, we're going to look at this a lot more intensively in a webinar that we're doing over the summer, because there's a lot of moving parts to this. The transitional care and the chronic care management can both be done by the same group, but there's a lot of different ways of how it's applied. And the chronic care management is kind of the follow-up to the transitional care management, but it's not limited to patients who have been discharged from the hospital. What the chronic care management program does is set up a procedure for a practice to get reimbursed to work with those patients each and every month that have 2 or more chronic conditions. So we will go into that in depth because it's a slightly newer code than the transitional care. It really just became fully effective, I believe, at the beginning of 2015, so it's been less than 2 years. And honestly, less than 1% of providers are using that coding now, so I think it's worthwhile looking at, and we'll spend a lot of time on that because it does have a lot more requirements than the transitional care. But these are 2 ways that will help you begin to manage your patient load better. But what I would like to do too is to say that, as I mentioned, we're going to be talking at the next webinar about the functionality that can be used to support these, what is being done out in the community through the 1422 grants to both provide patient education, but also to set up these programs and help you see how your EHR system can be set up to do some of this pre-diabetes screening and some of the other programs that go into these grants. Then we'll be talking about coding the next month, and the following one we'll be talking about the ambulatory care data from every community in the state where we've pulled data. What I'd say finally is if you are not participating in these grants and have not become part of the Ohio community that is contributing to this, because I have to say thank you to everyone who has provided us data with dozens and dozens and dozens of hospitals, you know, many physician practices. You know, I think people feel like they've taken ownership of this process because they want to know how their community's doing. As I said, we're all competitive. We all like to see how our own situation is being affected by what's going on in our community. But more importantly, I think people are really willing to, you know, participate in something that's going to improve the health and welfare of our state. So if you have not contributed and would like to, just shoot us an email and we will get out to you and show you exactly what can be done. Very simple data draw for what needs to be submitted, and we can make you part of the database. And with that, I'm going to turn it back over to Scott, and we can look at the questions. Okay.
All right, just give me a second here and we'll get our questions pulled up. Let's check the chat window real quick. Nothing in chat. And for our questions, we have somebody that said there were some sounds. Well, we have no questions. If you do have a question, please enter it now into the chat box. Just as a reminder, we have recorded this webinar and we'll upload it here in the next several days to the CliniSync YouTube channel. If you have any questions at all regarding this presentation or the project in general, feel free to email Cathy or myself and we will take care of you. And Cathy, no questions have came in.
Okay. Well, thank you all so much, and watch for the next webinars in the series so we can give you an update on the data and talk some more about how you can manage these chronic care patients.
And with that, we'd like to thank you all for attending today. And again, if you have any questions, feel free to follow up with us. Thank you.